one moment. And I am not here to host. I'm just going to share housekeeping slides and then with you. All right, one moment. Okay, I'm sorry, my phone is blowing up. So it's slowing me down a little bit. Everybody is here. I just need to get my slides going. Nita, can you let me know? Dr. Sharma, can you see my slides?
No, I can see your script.
Okay. You guys are going to see behind the scenes. One moment, please. Let me make sure I grab the right one. Here we go. There we go. That's the right one. How about now?
Yes, looks good.
Perfect. Thank you so much. All right, just keeping notes for all of our resources, event calendar, toolkit, and more. You can find it on myositis.org. Before we get started, our disclaimer, TMA does not give medical advice, and we ask every speaker to disclose any potential conflicts at the start of their presentation. This webinar is being recorded and will be available on TMA's YouTube channel. Please put any questions you have in the Q&A box. Any questions that you put in the chat box may be missed. Applicable questions submitted when you registered for this program are being entered into the Q&A by TMA staff, so no need to submit again. And questions that do not pertain specifically to this webinar may be answered in future programming. Feel free to use the chat to share where you are joining us from. All right, we're going to take a quick poll. Give me one moment. I have to find my poll options. All right. Okay, can people let me know if they see the poll? What have you done or are planning to do to raise awareness for Myositis Awareness Month? Select all that apply. You know what? You should be able to see it. Can someone confirm that you can see the poll? Oh yeah, people are answering. Yes, you can select all that apply. Thank you so much. All right. Oh, I love that people are keeping it simple. Just find one person who has never heard of myositis and talk their ear off, right? We've got some of our first pitch and proclamation 50 volunteers on. And please share in the chat. In the interest of time, I'm going to go ahead and share the results. All right, everybody. So having a conversation came in as in the lead. And then after that, sharing your story and donating to TMA to help support our mission, we're pretty neck and neck there. And I love about wearing the awareness gear, and I will tell you more about how you can ask your rep to co-sponsor House Resolution 277. One moment. Okay, I'm going to stop sharing that, and then I've got to go back to my slides. I need a production assistant. Okay. All right, let me get out of this. Dr. Sharma, do you see my slides?
Yes, it's on the poll one.
Okay, we want to make sure that you know where to access our events calendar and a list of all of our TMA groups. So those links will be put in the chat and they'll be in the follow-up slides also. You can ask your representative to co-sponsor House Resolution 277. TMA is proud to partner with Every Life Foundation, and that link will be in there. And Dr. Sharma will talk more about this historic legislation at the close. Lots of you already answered. You've already donated. You can do so at myositis.org/help, or we've got a QR code. And then now it is my pleasure to introduce Dr. Nita Sharma. She has a PhD in computer engineering from North Carolina State University and has held leadership positions in engineering and product management across diverse technological domains. She serves on TMA's board of directors, and she lives with her husband and 2 dogs in California and has 2 adult children. Thank you so much, Dr. Sharma, for hosting today's webinar. I will now stop sharing and you can take it away.
Okay. You're more than welcome, Rachel. TMA means so much to me and my family. So hello and welcome to everyone to TMA's Ask the Expert IBM Edition. We are so glad you are here. Please, I can see some of you have already done this, but please let us know in the chat where you're joining us from. We'd love to see how far the community has reached. I am Dr. Nita Sharma, member of TMA's board of directors and someone living with inclusion body myositis. Have had symptoms since 2012 and diagnosed in 2017. I'm very honored to be your host tonight. Since 1993, the Myositis Association has worked to improve the lives of those affected by myositis through research, advocacy, education, and support. We envision a world without myositis, and every day we work towards that vision together with you. These Ask the Expert sessions are some of the most important programs we offer. They bring you direct access to leaders in myositis research and care. Tonight is no exception, so take full advantage, submit your questions using the Q&A box, engage respectfully in the chat, and don't forget, you can share what you learned tonight with your healthcare team, your friends, and family. Now I am thrilled to introduce our expert for this evening, Dr. Merrilee Needham. Based in Perth, Australia, Dr. Needham is a highly respected neurologist and international leader in the study and treatment of neuromuscular diseases. She is specially recognized for her work on inclusion body myositis, IBM, and serves as a passionate advocate and researcher for those living with myositis. Professor Merrilee Needham is the current foundation chair in neurology, a joint position between Fiona Stanley Hospital, Murdoch University, and Notre Dame University, Australia. She's a consultant neurologist at Fiona Stanley Hospital, the director of research for the South Metropolitan Health Service, and the group leader, Myositis Discovery Program, Center for Molecular Medicine and Innovative Therapeutics, Institute of Immunology and Infectious Diseases, IIID, Murdoch University. She currently serves on TMA's Medical Advisory Board. We are honored to have her with us tonight. Welcome, Dr. Needham.
Thank you very much.
We will now move directly into the Q&A portion of our program. We have received many thoughtful questions from the audience, and I'll pose as many as time allows. So let me have a look at the Q&A section.
Linda's posted a couple already.
Okay. Let me start with one of them. Is there some prevalence of what I would call postprandial dysphagia with IBM?
I guess I wasn't really sure what Todd meant by postprandial dysphagia. Does that mean after you eat, you have trouble swallowing? I wasn't quite sure what that meant. Postprandial usually means after a meal, and dysphagia is difficulty swallowing. Certainly dysphagia is very common in IBM. Up to 60 to 80% of patients will have some trouble swallowing because of the skeletal portion of the oropharynx and the esophagus. So it's difficulty usually getting things down or things getting stuck quite high. But I'm not sure exactly, Todd, what you meant by postprandial dysphagia. So could you just clarify exactly what you meant there, please?
Maybe we can go on to the next question, and when get some response, we can come back to that. More AI question. Do you think AI might be useful to IBM at some point?
I think AI is going to be a useful tool broadly in lots of ways. I mean, AI can continue analyzing big data sets while we're all sleeping or on holidays. So I think AI will be helpful in terms of analyzing the large amount of data once we start to accumulate and join registries together from around the world in terms of analyzing, hopefully, risk factors for developing IBM. I think, that's where it'll probably come into its own. It's very useful for translating scientific articles into a podcast, a way to understand them. So AI can be very good at simplifying scientific articles into more sort of lay language. And we already do that for patients with our own articles in our team. So, I mean, I think there's already uses for AI. I think AI is only as good as the information put into it. So at the moment, I think the AI platforms where you have to enter data in or tell it which web pages to look at are more useful than just broad ones in terms of information, because otherwise it just pulls information from even non-reputable sites. But it's a tool. It's a great and it's a powerful tool, and it's only as we harness it going to become more useful. Nita, under answered questions, I just addressed to Linda that I would address those questions, so I haven't actually answered those too. So don't.
Sure.
Yeah.
So I think we got a clarification, the post-prandial dysphagia, and it says it's after eating that the person feels they will pass out.
So that is a thing not specific to IBM, but more common in other neurological disorders. And that's a product of the fact that when you eat, all your blood goes to your gut to help you absorb the nutrients that you've eaten. It's called postprandial syncope. So it's a real vagal response because your vagus nerve is very active. And so all the blood goes to your gut and leaves your brain and can leave you feeling like you're about to pass out. It is a thing. It's not related to IBM. It's often related to autonomic dysfunction. So your autonomic nervous system or your automatic nervous system is what controls all those background physiological activities that we don't think about: our bladder, our bowels, our guts, our heart rates, our blood pressures. Those things that we don't consciously control are controlled by the autonomic nervous system. And so if you're getting that sort of postprandial syncope, that implies that as your blood's all going to your gut to help you absorb those nutrients, you haven't got sufficient blood pressure to perfuse your brain, and your brain's telling you need to lay horizontal or you're going to run it, or it's going to put you horizontal. It's definitely not part of IBM. It's definitely usually related to something else, and you should go and see your physician about that. Yep.
What are the best exercises to keep active and slow IBM progress?
I'm a big fan of exercise. I think you need to combine both aerobic exercise, which is good for cardiovascular fitness, in addition to resistance-based exercise, which is good for building strength. So whatever program you're given should involve both of those. So aerobic-based exercise is those exercises that get your heart rate up. So walking, swimming, walking in water, cycling, they're sort of aerobic-based exercises. So they're good for cardiovascular fitness, your respiratory function, and overall health and well-being. So you should do some of those sort of things as much as you can within the realms of your own mobility, and combine that with a resistance-based program, which could be done sitting in a chair or laying on a bed. And resistance-based exercise programs are best done with light weights and more repetitions when you have muscle disease. So you want to avoid heavy weights. And it's weight-based exercises are really important to build strength. So that's what the weightlifters do to build sort of big, strong muscles, is they do heavy weights. But with muscle disease, actually, I want you doing light weights and more repetitions. So you need a program that's really prescribed for you with those kind of exercises, focusing on the really big muscles, the hip flexors, the ones that get you out of a chair, the quadriceps, they're the ones that keep you safe, particularly when your knee is bent or flexed. That's what stops you from falling. If you can build up your hip flexors, your quadriceps, they're very functional muscles, and I would definitely put a lot of attention to those. The core muscles are very important. and breathing. We do some breathing exercises with our patients, and that helps respiratory function and also swallowing. And then I think, we can't forget about the arms and hands. So, getting a stress ball, sitting in front of the television. There's lots of exercises you can do just while watching programs on TV or sitting in a chair, listening to podcasts. And it's best done very regularly. I tell my patients I want them to exercise really a minimum of 5 days a week to optimize the muscles they've got left. And that's, I think, the best you can do is a program that's built for you in a safe way that you can do to your level of function in your environment, and something that you can do pretty much every day.
Thank you. Given that early IBM symptoms in women, such as hand weakness, fatigue, and muscle loss, can closely mimic common aging or menopause-related issues like arthritis, do you believe IBM may be underdiagnosed in women? Any research to explore this possibility?
Yeah, that's I guess a great question. I mean, I think that's part of the difficulty with diagnosing IBM is that it can be quite non-specific, and in fact, it's often put down to aging and other things. Even for men, actually, in the first instance, it's often labeled arthritis or just aging. The fact that you're pushing out of a chair or you're having trouble getting up is dismissed by patients as well as doctors alike, actually. Is it underdiagnosed in women, and has that been researched? It's a hard question to research because we don't know what we don't know, I guess. So I think raising awareness about the fact that it's probably almost never normal to have to push out of a chair or up off the toilet with your arms. My 90-year-old patients can just get up, the ones that are really active. And so I think if if you're pushing up off a chair regularly and having difficulty getting up off the floor, you're either not doing it often enough and you're simply not strong enough. But there are some real red flags to suggest there are diseases happening rather than just general aging. And it's the specific pattern of muscle weakness specific for IBM, but other diseases also mimic, I guess, aging and fatigue. Fatigue is unfortunately fairly universal. So it's a very non-specific symptom. It doesn't necessarily imply disease. So, it's the pattern of muscle weakness, the difficulty pushing up off a toilet with your arms, unable to sort of grip a key. Those things are not aging. Those things are pathological, whether it's due to arthritis or muscle weakness, that's up to the doctor to work out. So I think it's just about raising awareness of what healthy aging and healthy menopause, I guess, looks like versus some red flag symptoms that you might raise. And I think seeing a really astute doctor that's able to distinguish between the two and ask the right questions, because we can't expect people, I think, to always be able to understand what they are. But I think that is up to the physicians to be able to sort of listen to what your day-to-day life is doing. And I think we'll only know if we're underdiagnosing it in women when we start to diagnose it more, perhaps, because at the moment, I guess that's not my experience, but perhaps they're not coming to my attention because nobody's recognizing it until maybe a very late stage. So I guess I can't really answer that. I don't think anyone's doing any specific research around that.
Thank you. This one a little specific, but maybe you can answer the general form of this question. Someone says they're diagnosed in February 2020 and wondering what symptoms start to occur to let you know the disease is progressing. So maybe you can answer as to how to know the disease is progressing.
I think it's most of my patients sort of recognize it by changes in function and day-to-day activities, things that they used to be able to do that they're now either struggling to do, or it's taking longer to do, or they're having to do it in a different way, or they're no longer able to do it. So I think for me, when I listen to my patients and I ask them about their day-to-day life, how is it getting out of bed, having a shower, getting dressed, eating breakfast, going to work if they still go to work, how is it exercising, can you still do the same program you were doing a year ago? Those are the sort of questions I would ask my patients to work out where they're at in terms of function. And function hopefully replicates strength and endurance to some extent. So if a patient a year ago could walk to work and get up a flight of stairs, but now they're having to take the lift and using an electric scooter to get to work, that's a big change in function. And that would be a red flag to me that they're progressing quite, much more quickly than I would expect. Whereas a patient that's still doing the same activities, in the same way, taking the same length of time as it was a year ago, still going to the gym and doing the same program they were doing a year ago, they sound relatively stable. And so, I think it's all around function, is how I kind of listen to the patients when they're talking to me. I first assess, where they're at, in part to work out what their needs are, but in part also to look at their progression and rate of progression, because that's certainly an area that all of us are trying to understand, because patients progress at different rates. Most patients will lose some strength year by year. Some patients seem to go very slow and stay stable for a very long period of time, and other patients actually seem to go really fast with IBM. There is a bit of a spectrum. They're the exceptions, those fast and slow. Most people, 80% are probably in that middle bit. But I'm very interested in the extremes of that, trying to understand what is it that keeps some people stable for 20 years and still ambulant at 20 years, while other people are in a wheelchair at 3. So I'm really trying hard to sort of work that out myself. So I do ask those kind of questions in a consult to try to understand progression.
Thank you. Again, this one a little specific, but maybe there's a generic, broader answer. Muscle biopsy showed a subset of IBM. I've been taking methotrexate for the last 6 months, and large muscles have gained a little strength. What's your experience with methotrexate?
So I'm not really sure, I guess, what that person means by a subset of IBM. I can only assume that only the inflammatory changes were seen on the biopsy, and perhaps the degenerative changes like the protein deposition or mitochondrial changes weren't seen, but I'm guessing. And that would be why the physicians prescribe methotrexate, which is a immunosuppressive drug. So we used to use this quite a bit. We use it as a steroid-sparing agent in other forms of myositis and polymyositis. And I think when the biopsy only shows inflammatory change, sometimes physicians will do a trial of immunosuppression because it looks a bit like the old polymyositis. And I'm not sure about the gaining strength. So the immunosuppressives usually may have some effect in turning off the inflammation in other forms of myositis. It doesn't seem very effective in IBM. So we've looked at longer term studies with methotrexate and similar drugs and haven't seen a good response in IBM, probably because the arm of the immune system that we think is mediating a lot of the damage is not amenable to the drugs like methotrexate that attack the dividing cells. And we can talk a little bit more about other treatments and newer treatments in IBM, because Alinda's already posted those questions in the answered question. I said I would address those. But so methotrexate in some of my patients, if they're purely inflammatory, maybe slow it down a little bit. It's a bit hard to be sure, but the data suggests that it doesn't really do very much in IBM. They're probably slower progressors or diagnosed earlier anyway. And as for gaining strength, I can only assume you're also exercising, because the drugs turn off the inflammation, but they don't make you stronger. The only thing that will make you stronger in any muscle disease is exercise. So if you've gained strength, then it's down to what you're doing rather than the drug. So there's not a lot of evidence in IBM that methotrexate does very much.
How common is hypophonia in IBM patients?
It's not uncommon. I don't know if that answers your question. We see that. So in a lot of my patients, they have involvement. Hypophonia is I presume talking softly is what they mean, or difficulty speaking. So and to speak, you need to push air through your vocal cords to project a sound. And so in most of my patients, the respiratory function sits around 70-80% of predicted. So it's down a bit, but not enough to really cause symptoms in most patients, except maybe during sleep. So hypophonia, low, soft voice, is not uncommon in IBM, in part due to the involvement of respiratory muscles and inability to push air through those vocal cords, and in part due to weakness around the mouth and the lingual muscles to make the sounds as the air is coming out. So it's not uncommon. It's not as common as, say, Parkinson's disease to have a soft voice, but certainly not uncommon.
Can you discuss your work on how mental health affects the progression of IBM?
I think mental and physical health, I think, are really intertwined. So we are doing some studies on mental health to try to understand this a little bit more. it certainly has an impact on quality of life and perceived quality of life. So I can have two identical patients in the sense that physically, if you look at them and examine them, they walk the same 2-minute walk, they have the same muscle strength, the same difficulties with day-to-day life. And one will walk in and tell me how great life is and how, they're having a wonderful life and things are good. And if I do a quality of life scale, they score very high. And the next patient, physically identical, walks in and tells me how terrible life is. They can't do anything they love. And how terrible life is, and they score very low. And the difference between the two patients is their mental space, because physically they're otherwise identical. So I think where you're at in your mental space and your perception changes everything in terms of your quality of life. And that probably changes your motivation to exercise, and so will have an impact on disease progression. But it has a major impact, I think, more than impacting the disease itself is your perception of the disease itself and the impact it's having on your life and your quality of life. So there's lots of studies being done in firstly recognizing, so we've published, I think, some recent articles around the prevalence of anxiety and depression in patients with IBM. It's very high compared to population normals and probably around the realm of other chronic diseases that are progressive that don't have a treatment. So I think it's not unique to IBM. I think it's a chronic disease problem, chronic pain. Patients have a similar problem with and prevalence of mental health involvement. And I think addressing it, we're still a little bit behind the 8 ball on the best way to address that. So I tend to take a bit of a multidisciplinary approach with that. I'm a very big referrer to clinical psychology, but you need to find the right clinical psychologist that understands what it is to live with a chronic disease with no really effective treatments right now, because they need to be able to give you the right psychological techniques to help you focus more on the things you still can do and making the most of those and remembering the things you used to do as sort of good memories rather than focusing on all the things you can't do, because that's quite a negative space to live if you are constantly faced day to day with difficulty getting out of a chair and getting off the toilet. Even going to the toilet becomes burdensome. Eating a meal becomes burdensome. Those day-to-day tasks, if that's constantly in your face about the things that you're finding difficult and hard, it's hard to kind of get into that more positive mindset around remembering the things you can do. So a big part of it, I think, is setting up your home environment to make it as easy as possible. So those things are not in your face all day, every day. Having a high toilet seat, having rails, shower chairs, setting up your home environment so living day to day is relatively, it's again, it goes back to just being just a normal daily kind of where you're not thinking about those day-to-day tasks. And then I think doing techniques like acceptance, commitment therapies, cognitive behavioral therapies, mindfulness is very powerful, I think, if you really can practice that. Mindfulness is the concept of being fully in the present. It's about focusing on the things you still can do here and now and not being fearful about the future and spending a lot of your mind time worrying and being fearful about the future or grieving for the past. That if you spend all your time grieving for what you've left behind, then you forget to make the most of what's here in front of you right here, right now. So I think if you can be taught those techniques by a really good clinical psychologist, they should be like a physio for the mind. And a lot of my patients, I mention the word psychology because they say to me, oh, but Merrilee, it's not in my head. This is a real thing. Or, they're for quacks that, but actually a really good one. None of my patients would hesitate if they had a fall to go to a physio to get the right exercises for their hip, to get back on their feet, to walk faster. And it's not what you do with the physio that makes the difference. It's the exercises they teach you and practicing it in between your physio appointments before the next appointment that makes the difference. So a really good clinical psychologist should be giving you exercises to practice between appointments so that if you find your mind starting to dive down rabbit holes or be fearful, those are legitimate things. And it's not about denying that they exist. It's about being able to contain them to a period of time. Then you're able to put it away and focus, spend most of your mind time somewhere else in a different headspace. And I think recognizing what your mind is doing and being able to practice consciously moving it into a different direction and a different way of seeing things makes a really big difference. So clinical psychology, I think antidepressants do have a role. I think they're very helpful, not in changing your circumstance, but perhaps putting your mind in a better space to deal with your circumstance. So I do think they have a role, and physicians should be able to, I think, talk to you about the pros and cons of those. I use them quite a lot with my patient cohort, even just for dips and periods of significant change. I think life can be tough, and life throws us lots of curveballs, and sometimes you reach your threshold, and just the medicines just pull you through those really difficult times until you're back on your feet. So I think mental health is under-recognized. I think we should be addressing it with all our patients. And it makes probably, I think, the biggest difference to quality of life of any intervention that we offer our patients.
Let's switch to physical exercise. A couple of questions on how much exercise. So how do you find a balance between exercising and strengthening your muscles and doing too much and negatively impacting your condition? Is it possible to induce a flare if you overdo a workout, especially weightlifting, or is it normal muscle soreness? So how much is too much?
That's a great question. So you just saw me have a drink of coffee. So imagine you have a cup of energy to use every single day. So you wake up in the morning and your cup is full. I think if you go and exercise, so even getting up and getting dressed in IBM, instead of it just taking a little bit of energy, you're already down to here because of the effort required sometimes in doing just those day-to-day tasks. If you then go to the gym and use up most of the rest of your cup of energy and you haven't got much left for the fun things in life, like having meals with friends or, reading a good book or whatever, then you're probably doing too much. You're using too much of your cup of energy for exercise. On days where you don't have anything else, those are the days to exercise a little bit more than the days where you've got really important family activities. You might exercise a bit less and keep the energy for the really important things. So I guess using your cup of energy wisely is really important, and exercise is a big component of that. As for over-exercise, I think you've got to listen to your own body. So I think you should never go from 10% to 50% of what you can do in a day. I think whenever you have muscle disease, it's a slowly graded exercise program. If you want to bump it up on a particular day, you bump it up by 5%. You don't bump it up by 50 just because you can, because you will feel it the next day. And in part, that is just the normal muscle DOMS, the delayed onset, muscle soreness that you get just because you're overusing your muscles. I haven't seen a lot of evidence to suggest that overuse is necessarily going to accelerate the disease or change the disease itself, but the problem with DOMS is that then you won't exercise for probably the next 2 to 3 days, and it might even put you off exercise altogether. So I do caution my patients about going all out. I think the way I suggest to my patients to start is find a level of exercise that you can do comfortably every single day, and just do that for 4 weeks, and then bump that up by 5%. And just increase it until you can just do that comfortably every single day, and do that for 4 weeks. And then you bump that up again by 5%. So over a year, you're making really good gains. But week to week, I don't want big jumps in exercise. That's for 20-year-old athletes that can bump up that fast, but not for us. Even middle-aged people shouldn't be doing that without a disease, let alone with a muscle disease. So listen to your body, use your cup of energy wisely, everything in moderation, but exercise. Definitely exercise.
One more on exercise. I've heard conflicting information regarding muscle loss. Is it possible to retain muscle strength by consistent physical therapy and/or exercising? Can loss be reversed?
So that's a tricky question because we lose muscle when we age anyway. IBM does cause muscle wasting in and of itself. Exercise won't entirely prevent that. What exercise will do is minimize what you're losing it'll optimize what you've got left and minimize your loss, but you're still probably going to lose muscle. And can you get it back? We're looking at that a lot. So some of you may recall the bimagrumab trial from 2013, 2014, thereabouts. Bimagrumab was a muscle building drug designed to get back some of that muscle you've lost. There's follistatin trials. We've looked at testosterone. so people are, and stem cells. So people are actively looking at how we can regrow muscles, because one of the big problems in IBM is actually IBM is probably there for quite some time before it's diagnosed, probably because the destruction of the muscle is matching your ability to regenerate the muscle for many, many years before it becomes a muscle wasting disease. And it's only when the muscle wasting starts to beat the muscle regeneration, because this bit gets exhausted, that we start to see muscle weakness and muscle wasting, and the disease becomes obvious. I think the disease starts way before we recognize it. And the reason I think that is because I've had a few patients I've followed for many years with high CKs reflecting increased muscle turnover, and then the disease becomes a bit more obvious 5-10 years later. So, and we know that in IBM, the ability to regenerate muscle is exhausted, actually. It's so I think by the time we're seeing muscle wasting, the body's natural ability to regenerate has been exhausted, and that's why you've lost muscle. And I think we'll need other things to help regenerate at that point, whether it's more stem cells or hormonal, or, so I think we are going to need to help at that point that you've lost a lot of muscle, but exercise will help to minimize that for sure.
Switching now to diet, what role does mitochondria play in IBM? Are there any recommendations regarding diet or supplements for mitochondrial health?
So we do see mitochondrial changes in the muscle biopsies. We think it's probably secondary to the cell stress. So we don't know that it's a primary driver, but it definitely is a component contributing to symptoms and exhaustion. So a lot of my patients report like a lack of endurance in what they're able to do because of the exhaustion. And that, I think, is because they're running on cheap batteries instead of running on the energizers, the lithium batteries that they used to run on. And that's the mitochondrial function playing a role with the symptoms that my patients complain of. So I do think it's a major contributor to the fatigue and exhaustion and exercise intolerance. With regards to treating mitochondrial abnormalities, exercise is right up the top, okay? Because of the way mitochondria replicate, exercise encourages the good ones that are functioning to replicate at a much faster rate than the diseased ones and the ones that aren't functioning. So exercise is the top of treatment, actually, for mitochondrial disease. So I treat some patients with inherited mitochondrial disease, and exercise is top of that list. So you don't get away from exercise, okay? With regards to supplements, I do actually try coenzyme Q10 and other mitochondrial supplements, MitoCare. It won't necessarily improve strength, but it can improve endurance. So I get my patients to try it for 6 to 8 weeks and find an activity where they're really struggling to complete it, and look at that as your measure to see whether the supplements work, because you don't want to be wasting heaps of money on supplements that aren't doing anything for you. So find something that you can measure in yourself to work out whether the supplement has made a difference to how you feel or what you're able to do. And you're looking for endurance, so doing it for longer rather than strength, because that's not a good measure of mitochondrial function. And if it works for you and it's not causing side effects and not going to break your bank, by all means, I have no issue with the usual mitochondrial supplements. And I encourage all my patients to try them because some patients do derive benefit. And so if it gives you benefit and it's not going to break the bank, go for it. And they're not causing harm. So I hope that answers your question.
Question on diaphragm strength. So what's the current consensus regarding the effect of IBM on pulmonary function, including diaphragm strength and phlegm management? And kind of a related question, what can we do to improve diaphragm strength?
Yeah, so breathing muscles are the intercostals as much as the diaphragm. So I think IBM seems to affect these muscles probably even more so than the diaphragm. So the diaphragm, if that's weak, causes problems when laying flat, because you can imagine that if you lay flat, you've got all your tummy contents pushing up against the diaphragm. And so if the diaphragm's weak and can't push it down when you're laying flat, that's a real sign of diaphragmatic weakness. And that's not something I usually see in IBM. It's not a laying flat problem. It's a sleep disordered breathing problem, probably more due to these muscles than the diaphragm. We know from our own studies that using IMST and EMST devices, IMST has really improved respiratory muscle strength in our IBM patients, but didn't really result in improved function. But, I'm a big fan of improving respiratory muscle strength because cardiorespiratory fitness for exercise and good quality sleep is really important. So weak muscles will get weaker when you sleep. And so actually one of the first symptoms of breathing muscle weakness in IBM is sleep disordered breathing, a bit akin to sleep apnea. And so the way that manifests in patients is that you wake up not feeling refreshed like you used to, and you're more tired during the day. And by tired, I don't mean physically fatigued, I mean sleepy. And so you're not off to sleep if you're not being stimulated. So in front of boring TV shows or reading the newspaper, if it's not particularly interesting, you're not off to sleep, and that's unusual for you. You should definitely go to your physician and tell them those symptoms. That's excessive daytime somnolence. That means your quality of sleep at night is probably not what it should be, and so your body's trying to catch up during the day. And your brain doesn't think as well, and you're often a bit more emotional if you're sleep deprived. So it actually is a major cause of morbidity. So that's the breathing muscle weakness. The difficulty managing phlegm often comes from these muscles, in fact, rather than these muscles. So if your swallowing muscles are weak, normally we would swallow about maybe a liter and a half of saliva a day, and most of us don't think about that. But if these muscles aren't working so well, you have to consciously think to swallow saliva. And so sometimes it accumulates in the back of your throat because you haven't swallowed it and got rid of it in the way we normally would. And then it can go the wrong way into your lungs, and that can cause problems and coughing. The way around that, if it's very mild, you can try to build these muscles up with the EMST device, and so the speechies have other exercises to help try to rebuild some muscle strength here. That will help. Sucking on a lollipop sometimes makes you swallow, or sipping on a drink of water. The dentists don't like the lollipop method because obviously you're sucking on sugar most of the day. But what that does is make you swallow saliva quite a lot as you're sort of chewing or sipping. And that helps encourage you to actually swallow the saliva down. But if it's a really big problem, actually, we have to reduce your saliva production down a bit using anticholinergic type drugs. And I use very mild ones often in IBM. And you just have to be very careful if you dry it up that it doesn't become thick and sticky, because that's even more difficult to move than a thin, runny saliva. So saliva management in very severe bulbar weakness can be very tricky, but the MND doctors are pretty good at it because we do it in motor neuron or ALS all the time. So in IBM, it doesn't tend to be as big a problem as motor neuron disease. Does that answer your question?
I think it does. I'm combining a question on diet and supplements. One is how does diet affect IBM? And the other one is how about creatinine and or testosterone to help build muscles?
There haven't been any very good studies done on diet in IBM, but in muscle disease in general, I always make sure my patients are consuming sufficient protein. So protein's the building block of muscles. And if you're not eating enough protein, actually your body breaks muscle down to keep your liver and your brain going. So actually eating sufficient protein is very important in any muscle disease. So that's step one with the diet. There aren't specific diets, I think, that are more useful than any others, and nobody's really done any studies to prove that one way or another. So a good general rule is everything in moderation, as long as you're having sufficient protein for your body's needs, sufficient energy, so you're not losing, too much weight unless you need to. So that's the carbohydrates and fat proportion. Some of my patients love diets, particular diets. I know there's been a study published on the ketogenic diet. I don't think there's sufficient evidence for any one diet over another. Eat healthily, lots of fresh fruit and veg, lots of color, antioxidants in your diet, plenty of protein. A bit of protein with each meal is usually sufficient. So that's the diet question. Oh, supplements, creatine. Again, I think supplements come into play if your diet's insufficient in something. So if you are vegetarian, you might want to take supplements with, vitamin B12, iron. If you're not eating enough protein, then creatine and protein supplementation can be very helpful. So I think supplements are there to supplement your diet if it's insufficient in something. So if you have a really good balanced diet, you probably don't need supplements.
What's your opinion on BFR?
Sorry, BFR, what's that?
Blood flow restriction, blood flow restriction exercise.
Look, we did a study on this, which was negative about 20 years ago, and there've been a couple of positive studies since then. to suggest that it's helpful. It's I think I don't have a particular thought on it. I think if you enjoy, I think exercise has to be enjoyable so that you do it every day. I think it's the consistency doing it is probably as important. I think if you have easy access and you enjoy blood flow resistance exercise, there's some data to suggest that it helps build muscle faster. Then go for it. If you don't enjoy that and you don't like exercising under some relative ischemia and it's painful, then just do other exercise instead. I think I would rather my patients exercised than not at all. And therefore it has to be enjoyable and fit in with your life to make it that and make it consistent. So I don't feel strongly either way with blood flow resistance exercise. I think it's interesting, but not often practical for patients to do at home.
A question on, is there an IBM progression chart?
That's a great question because we're trying to look at the best way to measure IBM progression. And so most of us around the world are using IBM FRS, the functional rating scale, to measure progression because it's sort of a bit encompassing of leg, arm, swallowing, and it's reflecting function, which is what patients recognize, so probably most of us would use that to measure function as much as, say, quadriceps strength and walking distance. But no, there's no chart at the moment.
Okay. Lots of questions on the ABCURO trial. Is that something that you would be able to answer?
So in terms of the ABCURO trial, I think it's really exciting. It's finished recruiting. They're still collecting data. So it's way too early for any kind of results. We don't know yet whether it disease modifies the progression in IBM. So we're waiting anxiously for those results. So I think, I don't know when they're expected. The company might have something on their website around that, but I think the trial's ongoing, so it's a little way away yet. But the company are very motivated, I think, to get results out as quick as they can. So as soon as the results are available, I'm sure we're all going to hear, and we're all waiting, I think, with bated breath around that.
Thank you. There's interest and update on the sirolimus study that you are leading, as well as any clinical trials in IBM broadly that you would know about. Okay.
So the sirolimus trial is also exciting, I think, because the data from France was very interesting. So the study is due to complete in Australia. So by the end of this year, in the US, that's sort of ongoing, I guess, at the minute. And Europe is yet to start. So the difficulty with doing investigator-led studies is the funding was quite piecemeal. So Europe ran a little bit behind trying to fundraise for the study over there. And the costs are around the drug and dispensing the drug mainly. So Europe are hopefully going to get up and running later this year. And we are planning an interim analysis of the data in sirolimus for early next year. To see whether the effect's either been excellent or if it's totally futile. So we're really hoping that we're going to see a positive result in the interim analysis even, but that's due early next year. So that's exciting. And then if there's not enough data because the interim analysis is basically at the halfway point, then the Europe study will be even more important to make sure that we get the answer that patients need. Is sirolimus a disease-modifying drug in IBM? And that's the question we're trying to answer. Does it slow progression? The French think it does. I'm hopeful. So fingers crossed that we hear something at the interim analysis. Otherwise, it's still a good 2-3 years away by the time Europe finishes.
This is on progression. Have you seen IBM patients getting to a plateau in later stages of the disease, wheelchair, or are you destined to be unable to care for yourself?
Again, every patient's a little different. So I've got some patients 20 years down the track that are still reasonably independent. They just have more trouble day-to-day doing things and do require little bits of assistance. I have other patients that do continue to progress. The hard bit is, I think, once you end up in a wheelchair, is you are often doing a lot less. And so the muscles, you do lose that ability to do things for yourself a little quicker because you're not doing the things that you used to be able to do. So I guess, do I see a plateau? It's a bit hard because we're talking about function. And so I think, you know, you go along and you can function at a certain level until you can't, and it feels like a big drop. And then you go along being able to, for example, walk with a stick for a while until you can't, and then you end up with a frame and then a wheelchair and so forth. And so it feels a bit more like a stepwise approach when you're talking about function. And so perhaps when you hit a chair, do you plateau? Yeah, probably for a little while functionally you do. You know, you get to a point where you can stand to transfer but not really walk long distances anymore, but you still have enough arm function to self-feed. Is it inevitable that you're going to need more help? At the moment, most patients do require more help as time goes by, but it's not universal and it's not everybody. And it does depend a little bit on your attitude and your determination and your exercise. But in some patients, even despite all of that, still do need some help. And others seem to do plateau and go very, very slowly for a very long period of time. And they're the ones that do exercise every day religiously, eat really well. But it's not, yeah, you can do those things and still progress. So I can't really answer that for your specific I guess, place. But I guess for most patients, the decline is relatively linear, all other things being equal. So if your diet, exercise, everything's optimized and you're progressing, the degree of change that you expect in the next 12 months is roughly speaking the same degree of change that happened in the previous 12 months. So if you have hardly changed, you're probably hardly going to change again in the next 12 months. So you can help, I guess, work that out with your doctor by looking at what's happened to you in the past.
Okay. Kind of a related question. Do you have any theories as to why some people with IBM progress faster or slower than others?
Not really. I mean, I think it's a tough one. I think some people perhaps have a lower reserve to start with. Some people don't exercise, and they definitely progress faster. Some people don't eat very well, and they definitely progress faster. And I think, unfortunately, even if you optimize all of that, some people do just progress faster. And is there a double hit happening in their genes? Is it that their cells are less able to deal with the oxidative stress or the protein buildup than somebody else? I do think genetic susceptibility plays a role, both in the disease, getting the disease itself, but also in how your body responds to having the disease. So I think it's probably going to come back to genetic factors, you know, how your body deals with these sort of things. Yeah.
This is a question about who to see. So did I hear that they've decided IBM is not an autoimmune disease? Should IBM patients be seen by a neurologist or a rheumatologist?
It's still debated whether IBM is truly an autoimmune disease, though the AbCuro hypothesis is that it is an autoimmune disease, but mediated by an arm of the immune system that isn't amenable to most traditional forms of immunosuppression. And I think most of us believe probably it's primarily an autoimmune disease that then becomes a degenerative disease. So rheumatologists are very good at managing inflammatory diseases. Neurologists are very good at managing degenerative diseases because that's kind of our referral bias. IBM usually presents to neurologists because it's a lot more subacute or chronic in its onset and progression. And so patients are often referred to neurology because the onset's over months to years, whereas other forms of myositis is over weeks to months. And so the general sort of doctor population recognize that's probably autoimmune and send it to rheumatologists. I think it just depends on your local rheumatologist or neurologist who's got an interest. I would see the doctor that has an interest in IBM and who understands muscle disease, because you just want to see a doctor who's interested in what you've got, keeps up to date with the literature, is going to follow you with time and not just dismiss you and say there's nothing we can do, but will keep you on and monitor you and work with you to optimize your function and keep you up to date with some trials. So I don't care what the specialist of the doctor is, see someone who's interested in your condition.
This is someone who's had IBM for 21 years, is permanently in a wheelchair bound and needs help in nearly all daily functions. What would you recommend for someone in that position to do to help keep them getting no worse than they are now?
Do what you can do. So, I mean, if you're, I don't think exercise should ever be discouraged. So I think if you're in a chair and you're struggling to use your legs, and you're a hoist transfer, you should be focusing on your core muscles and your upper limb muscles and your swallowing and breathing muscles. So there's lots of muscles that you can still exercise. So I think if you're ever being discouraged from exercising, then you're being given, I think, wrong advice, actually. I don't think there's any evidence that overuse, and I don't think you should give up if you're in a wheelchair. I mean, we're more than our legs. You know, you don't need to walk to be valuable. And I think, you know, the fact that your brain is working and that you're still breathing and alive, you should live, and there's lots you can still do. So I would absolutely suggest you're given an exercise program with your arms, your shoulders. You know, if you can still slide board and push yourself, great. If you can't, you still want to be able to grip and self-feed. Like, there's still lots that you can do. Yeah, don't ever be discouraged around that.
I think the last question, but I'm just going to club two of them. Anything on gene therapy research or solutions or stem cell?
So people are looking actively at stem cells to regrow muscles. That's a little way away probably yet, because it's working out how to even get the stem cells into the muscle is hard. Do you use the blood, the arterial blood? Do you directly inject them into muscle? So people in muscle disease more broadly are looking at stem cells to regrow muscles, but that's a little way away, I think, yet, because the technology is not quite there. Gene therapy, if we could find a gene that was causing this disease, then this disease becomes amenable to gene therapy. But at the moment, what we found in IBM is that you have a genetic susceptibility. So it's in the autoimmune genes, the HLA, but also some genetic predisposing factors in your protein breakdown pathways. And perhaps in IBM, it's both together. And then it's how your body responds to environmental antigens like viruses or something. We're not really sure what triggers IBM. But it's how your body responds to those environmental triggers that probably causes the disease. And so gene therapy at the moment is probably a long way away, because we don't actually think IBM is a genetic muscular dystrophy in that it's inherited and goes from mother to son or whatever. We think that you inherit genetic susceptibility factors, and then something in your life will trigger the disease. And it triggers this sort of state of chronic inflammation and accelerated aging and protein deposition. And so we might be able to manipulate genes to modify that trajectory, but I'm not sure we'll have gene therapy in the same way we do for genetic muscle diseases to sort of stop the cause of the disease. Does that make sense?
Yeah, thank you. Sadly, we are out of time. So Dr. Needham, thank you for your expertise and your dedication and your very thoughtful answers to all the questions. And thank you to everyone who joined us. But before we go, one last important reminder. Each of you can take action right now to help raise national awareness of myositis in the US. Representative Rich McCormick has introduced House Resolution 227, a resolution supporting the designation of May as Myositis Awareness Month for the entire country. Visit the link in the chat to learn how you can show your support and help amplify our community's voice. Thanks again for attending today's webinar. Take care and stay connected. And thank you, Dr. Needham.
Bye.